Well, good afternoon, everybody. My name is Garrett Schmidt, and I'm the managing editor for BBC Exhibit Hall. And so glad you joined us for today's live webinar hosted by mPulse Mobile. And it is titled The Explosion of Value-Based Care, How Technology Can Help Us Scale. And I'm really excited to hear from our presenters today, which I'll introduce in a moment. A couple items of note before we get started. All attendees have entered today's webinar in kind of traditional format, so we can't see you or hear you. You don't need to worry about muting your microphone or anything like that. During the webinar, we do want to hear from you. So during the webinar, we will have a time for Q&A towards the end. So at any time, if you have a question for either of our speakers or just in general, you can ask that using your control module. It's not the chat, there's actually a little question area. So if you'll put your question there, we're gonna get to as many of them as we can today during the allotted time. If we don't get to yours for some reason though, don't worry, someone will reach out to you via email afterwards and make sure that your question is answered. So looking forward to hearing from you then. And lastly, today's session is being recorded. So what's going to happen is after we're done, you'll receive an email from one of us, and it will have a link to the recording as well as the slides where you can download them. And it'll be a link that you can share. So we hope that you do and rewatch it again. And then we'll tell you also if you would like to be able to get in touch with the speakers, we can tell you how to do that. So finally, without further ado, I wanted to briefly introduce our presenters today. Mr. Aram Kodaguyan, he is the Director of Value-Based Care Solutions, and I'm sure I slaughtered that last name, Aram, so my apologies there. And then also Leonard Lindenmuth, and he is the VP of Strategy and Population Health with Bassett Health. So welcome, guys.
Thank you. Appreciate it. Let me jump in probably and just introduce myself real quick. So I've been at mPulse Mobile for about 5 years, live in the Los Angeles area. Currently have a bachelor's degree in economics, beginning an MBA program with a focus on healthcare administration. So here at mPulse Mobile, what I do is I focus entirely on the provider side of value-based care solutions, working with ACOs, MSOs, CINs, IPAs, and more, to really improve patient engagement and then get different populations, whether it's Medicaid, Medicare, and commercial, to take the next best action, right? So they remain healthy while preventing further health issues. And then obviously this helps with value-based care organizations because they benefit from keeping total cost of care down and then closing the gaps, right? Yeah, that's pretty much about me. I'll pass it over to Leonard so he can introduce himself.
Thank you. I'm Leonard Lindenmuth. I'm the Vice President of Strategy and Population Health at Bassett. Bassett is a 5-hospital system in Cooperstown, New York, the home of the Baseball Hall of Fame. Our geographic reach is, and we cover an area about the size of the state of Connecticut. That is between, to the east, Albany, New York, to the west, Syracuse, New York, and to the south, kind of Binghamton, New York. So it's a piece of land that's really large. We're a completely integrated system, 600 physicians that are employed by Bassett. We're clearly the dominant player in a less populated area. We reach out into other areas as well. We've been in the value arena since before 2014. So we have 10 years experience in the Medicare Shared Savings, ACO. We do a number of value-based programs with commercial insurers for commercial lives. We're in the Medicaid arena for value-based care with a couple of national players and the local Blues. We have our own self-funded health plan that we learn a great deal from, but we've developed for a relatively smaller market. We've developed a lot of depth and knowledge in the complete world of value-based care. So we've kind of leveraged that to move ourselves forward strategically. And we have a belief, particularly with our new CEO, the importance of value-based care to kind of move the needle forward and to look at the things we need to do as being good community stewards and good players in the larger ecosystem. So happy to be here today and looking forward to work with Aaron on a number of different topics.
Appreciate it, Leonard. Thank you. So some of the topics we'll kind of be discussing today include a little bit about mPulse Mobile, Bassett Health Network, as Leonard kind of introduced, how the healthcare landscape is shifting from a fee-for-service model more towards a value-based care model, especially we've been seeing it in the past 2-3 years, right? Then the importance of an annual wellness visit and preventative care. So how both are really crucial for HCC recapturing for RAF, and then closing gaps among other initiatives. Then moving on to the best way to engage patients to deliver outcomes that I just mentioned, and really getting effective patient engagement, cost savings and ROI potential, and then we'll try to do our best to answer any questions you might have at the end. Before we continue, quick polling question. Garrett, I'll have you kind of take that away.
All right, I went ahead and launched it. Aram, I'm not sure, are you able to see it from your end?
Yes.
Okay,
Yes,
so
see it.
this is, are you currently in one or more of the following value-based program models? So go ahead and select all that apply, and we'll give it a couple more seconds here. We still got some answers coming in. We got a good variety coming in, so this will be good to discuss here.
Good.
I'll give it about 5 more seconds here. An extra long 5 seconds because some answers are keep coming in here, so we'll give it a little extension.
Worth the time. It's good.
It is worth the time, yeah, for sure. Okay, let's do 5, 4, 3, 2, 1. Okay, we're gonna go ahead and close it down now, and I'm gonna share the results. Aram, are you able to see the results on your end?
Yes, I do see it. And that's interesting because, again, we do see a healthy mix like this where, there's that ACO, MSSP, or REACH program. And then, again, when we think about ACOs, predominantly it's Medicare, but then, of course, there's a lot of those value-based care agreements with Medicaid plans and commercial, as Leonard kind of mentioned as well. So interesting to see, and seems to be the norm now.
Great. Okay, I'm gonna go ahead and shut it down.
Alrighty. Let me get over to the next slide. Okay. So again, what we do at mPulse Mobile, right? So some people think we're a cell phone company because of the name. While they're on the right track, we're actually not a cell phone company. We run consumer engagement programs for healthcare organizations, leveraging our behavioral science and conversational AI technology. So we have an omni-channel approach, which basically means we do bi-directional, that's two-way communication through email, IVR, or again, over the phone, so that's interactive voice response, and then SMS text, which is by far the most effective that we've seen. So we get patients to take a healthcare action. So we provide them the best healthcare. You can provide them really the best healthcare, but what you still need to do is get them to show up, right? And that's where we come in. As you can see, mPulse Mobile has been doing this for years, only in the healthcare space, work with many payers, many providers, large and small, have over 1 billion annual engagements, and we'll kind of go into details of that soon. I'll pass it over to Leonard. You can speak a little bit more about Bassett Health.
Yeah, I think, the emerging thing I hear from physicians that I know is the whole issue about the things they really need to know is they need to spend more time with their patients, and they need to spend more time with the patients' families. And I think any tools that kind of enable that to happen are going to be valuable. Certainly, if we see the movement from fee for service, where you don't get paid for those kind of valuable engagements, to more of a value-based and population-based, panel-based management. So I think the things that I've heard resoundingly in the last year or more from physicians that I know really well has been that they'd like to spend more time, they'd like to have that engagement, and again, things that facilitate that are important parts of that process.
Yeah. Alrighty.
So I
it
probably
seems like
covered the mission and everything about it, but it's the one thing we're finding, which I think ties in well with what we've been talking about, is we really, the 20% that's responsible for somebody's health inside the clinic, and the 80% of the social determinants outside, we've started to view ourselves, in addition to always being a community asset, but we want to be a Bassett, at least an anchor institution, which is really, interacting with people, whether they're a Bassett patient or not. We have 5 principal counties where we're the dominant player in, and we serve those that come to see us, but we're starting to really rethink about the whole part of what's population health, and probably the role of hospitals and integrated delivery systems is to really be that fundamental source of health knowledge and organization and everything else for community. So, again, it comes down to a lot of engagement, a lot of, bilateral discussion and interactive work. So it all fits in well, I think, with the whole story.
Yeah, it makes sense. Well, I'll move on. Again, the changing landscape, that's what we're going to be focusing on in this section. So we'll have kind of Leonard, will be discussing the changing landscape in the value-based care versus fee-for-service, and what basically the future is and where healthcare is headed in the future.
Okay, so this slide kind of talks about just the general growth of the ACOs in the last 10 years, or the last probably 13 years now. But you see we talk about the explosion. The graph really shows an explosion in both the number of people covered under ACOs, the number of ACOs involved. There was some consolidation of the number of ACOs, but those ACOs that were consolidated really resulted in more members, more attributed population inside their ACO. So, I'm trained as an economist as well, and we probably tend to see the world differently. It's right, appropriate distribution of limited goods, and I've been on the provider side. I've also, dabbled in the side of buyers of care, whether they're employer groups or whether they're, groups together on purchasing healthcare. But, it goes back 40 years, even when I remember Chrysler Company, and it's in some of the healthcare books, they looked at, competing internationally with Toyota, and they said they have to add another $2,000 onto their car, back when that was a significant part of the car cost, to be able to pay for healthcare. And that sometimes the largest supplier in the supply chain for those companies that are not in healthcare is often the local blues or, the large payers. So it's a part of, I think, the way I've always looked at it, as a part of global competition, is how we, take care of people and how we spend, how we're stewards of this money and keeping people healthy. And we, fundamentally probably haven't done a great job at it. I remember back when GDP for healthcare was like, 12 or 14%, and people thought it was going to collapse. And already it's above 20. So, with less better health outcomes than other countries. So if you look at the global thing, the whole global picture, as I like to do, this is part of who we need to be as good corporate citizens, and good part of that healthcare and economic ecosystem. But the numbers are kind of astounding, particularly when you think of what we have now. I think it's $6 billion and change in managed or value-based care, and in the next decade it's supposed to go up to somewhere around 30, I think almost 33 billion in that. So that's a year-over-year growth of somewhere pushing 20%. That's astronomical growth, right? And I think the big thing about value-based care is people are understanding it, and while they may not fully understand it and they have different views, it's part of that assimilation of what it means. And I'm often asked by some providers, what's the difference between managed care and value-based care? And managed care back in the day was really focused at really managing more cost and not being responsible or accountable for the cost and quality. So that whole movement and mindset change into accountable care means that, we're part of the supply chain and keeping people healthy. And we're accountable for not only the cost piece of it, but the quality piece of it. And that, for economists, creates the whole equation that's called value, right? Value equals quality over cost. And if you improve the quality and keep the cost the same, you create a greater value. And if you flip it around, you create a greater value. And if you can make impact on cost and improve the quality, you've really got a double win there. So, I think it's who we need to be. We're not isolated from, the economic environment. We've, for years, seemed to think we somehow exist outside of that. But I think we're key, movers inside that, and we need to be more accountable and more responsible. But I think it's going that way. It takes forever, but I don't know that this trend can be turned around or that it should be. So
yeah, makes sense, 100%. And then kind of your thoughts on this, Leonard, and kind of some of the topics over here that you're seeing on the screen. Would love to get some feedback from you on that.
yeah, key. I mean, data interoperability. We're on one EMR, HMR. So that helps us as a fully integrated system. But I've seen people put together interoperability through different exchanges. That's a great thing. Getting the whole picture. It's funny. We get direct claim line feeds both from Medicare and then from our commercial payers that are either in Medicaid, safety net programs, or in commercial, and that's huge. Data accuracy is always a struggle. It's kind of a goal. It's aspirationally. It's not a we always find things wrong, but that goes both ways, and that's part of the process. Key, we're working together. We were one of the performing provider systems for the last 1115 waiver in New York called Disrupt. But it's the unnecessary care or the low value care, which are things like ED and preventable care, that we need to move. There's high value care, and then there's kind of low value care, meaning things that are done that may be expensive, that don't impact somebody's health status. I'm becoming a big advocate of the whole thing with provider burnout. Many of the primary care physicians truly get done. They call it pajama time. They're doing notes and Epic at night. I read a study, and somebody else reminded me of it just the other day, that the average time for a primary care physician to get everything done they need to get done would be 29 hours in a day. So we see firsthand the overload of work on physicians, and particularly primary care. But we need to help make that job easier. I think part of it is going to be technology. Part of it is going to be thinking about how we manage populations and panels, not individuals. We currently don't pay for sitting and talking and getting to know the people on those kind of like softer side issues that are very important in somebody's health and how it works. So, doing that is clear, is that we need to re-engineer the whole payment structure. But technology is obviously a tool to get there. We use remote patient monitoring. We're in a very sometimes rural region. We're exploring digital wearable devices. We've even done some things with phones, and this, access to the internet is a thing. It's considered a social determinant of health. So we ran one program where of the 10 people that we signed up, 9 still had flip phones. So we had to kind of think about how we, get a smartphone to people. And these are all challenges. But I will say in the recent times that we've seen complete thinking about it that we never experienced before. So I think we're on the right path. It's not an easy path. It's not, there's less people that think it's a conspiracy now, that value-based care is somehow kind of a conspiracy, and at least accepting. And you have listed there one of the things, leakage, and we see the repatriation of patients back to those that are attributed back to our system is an important part of managing the whole equation. So
yeah, it makes a lot of sense. And for that ED utilization and provider burnout, I think it's part of that quadruple aim. And I had called my cousin a couple weeks ago, asking her kind of a couple of questions and checking in, and she's an ER doctor. And she just sounded, I mean, the first thing she said is, I'm so tired. Like, there's too many people coming into the ER. It's just overwhelming. And it was just interesting though, because I hadn't even asked her about it. And she just kind of mentioned that, you know, and just out in LA over here. So it's interesting, and I'm sure it happens, you know, all over. It's the same issue, and really educating them on the correct uses of the ER is a big piece.
Yeah, absolutely. Yeah.
Alrighty. So now I'll kind of get into the importance of one major tool that should be leveraged more in the value-based care space, and that's really that annual wellness visit, right? So in a Kaiser Family Foundation article, Medicare enrollees have continued to rise from the year 2000 and on. So in the year 2000, we're seeing 39.7 million. By 2020, that number has gone up to 64 million. And then by 2050, it's estimated that will be close to 90 million lives covered. That's no small amount. And then spending also is increasing as well, right? So spending on Medicare is estimated to be about 12% of national healthcare expenditure, with CMS estimating closer to 20% in 2024. So Medicaid spending is also, again, close right behind. And how can we actually get this value-based care and make a difference, right? So the best way to do this is really keeping populations as healthy as possible now and for the future. And that's where the annual wellness visit comes in. It's really designed to assess a patient's current health and then create a care and prevention plan for them. The problem is that it's not utilized enough by payers and providers in Medicare and Medicaid as well. So now, you know, for this webinar, we'll be focusing on Medicare, but it's all around important for all health lines of business. And then to be successful, what you need is a good internal process, good coding and physician training, and that digital presence for operational efficiency. Again, this is something that Leonard kind of just mentioned. They're all on one EHR. Mistakes are going to be made, but again, the coding training is a very big piece of this, right? And these are really keys to having a streamlined annual wellness visit program. So if you have some or all of these in place, the benefits from an annual wellness visit can be really great. On top of helping build stronger relationships with your patients and improving their health, there are major financial benefits that can be gained, right? Including beneficiary attribution for ACOs, because annual wellness visit billing codes count towards attribution. Then you're understanding barriers and SDOH with an HRA or other questionnaires which can be completed ahead of time. We actually have a program about pre-visit HRAs and others like kind of CAPS and social needs surveys using those omni-channel communications of email and SMS. And that's been successful. Again, it's less time at the office because, again, annual wellness visit's not a 5-minute kind of appointment, right? It does take some time, usually 20, 30 minutes is like the average. Then, of course, recapturing HCCs for risk adjustment, closing gaps in care, and then the reimbursement for annual wellness visits and advanced care planning, which I'll kind of get into. But over here, you are seeing that only 25% of Medicare Advantage beneficiaries receive an annual wellness visit, and then 45% of all beneficiaries have 4 or more chronic conditions. And the top tier, again, what you want to strive for is that 85% recapture rate, which will not result in a downward adjustment of the HCC risk score in about 90 and 95% of cases, which is great. And then there's that 75%, which is fair, and then the 60% recapture rate, again, which is considered poor. And just to kind of sum it up, it's really great to have that annual wellness visit program. It's a critical component of HCC recapturing, but again, closing gaps and other things. And, you know, we want to keep it at that 85% or get it as closely as possible to that number.
Yeah, that's a great, series of comments about that. When I came to Bassett, we were somewhat adverse to annual wellness visits. There was confusion on what they meant, how they interacted with the patients. We've kind of overcome that, which is a good thing. We've adopted it more, and it's key to accurate representation of the disease burden on the population, right? So we undercode, and we're starting to code more appropriately. But our ACO, given our demographics, where we are, rural area, aging population, the whole thing, and particularly the workforce, we're below 1, and it's estimated we should be about 1.03, 1.04. That's a huge swing financially. So it handicaps the providers, but if you appropriately code, it really, you get to know your patients a lot better, right? You understand it better. That when we've been to the financial seminars, they say, if you don't keep coding somebody who has amputee that miraculously after 4 years the limb grows back, and it's it's an absurd thing, but it apparently does that. Our physicians didn't know how to really understand that. They thought they did it well enough. So we've adopted much more, and when physicians, I think, find out what ultimately the goal is and what the appropriateness of that is, we've not had the problem of having adoption from them. So it's I think such a key thing, and there's so much focus on it. There's a lot of companies that can help you out with that, but it is as mentioned, it's just something that I think you all know that it's a good thing, and the adoption of it is great. Extending it to other populations would be helpful as well. But coding is, if I had to point to one thing on the path to success at Bassett, that's changing the mindset of coding and getting people involved. But that starts with everybody in the primary care office, from the nurses to the MAs to everyone, and rolling that forward with the physician. So it's key. So
that makes sense. Makes a lot of sense. Kind of going into a little bit more in depth, really, on HCC recapturing, and Leonard kind of mentioned this, but basically previous year's HCCs are removed and must be recaptured each year to get the correct RAF score, right? So chronic conditions and disabilities like diabetes, amputations, again, like Leonard mentioned, need to be coded every year to count towards RAF. And this is really best done during an annual wellness visit, because there's time set aside for it, right? It's not someone coming in for an appointment that quickly needs to be pushed out. You actually put this time aside for it. To give an example of the importance of annual wellness visit, I'm putting two scenarios kind of up there, scenario 1, scenario 2. You're seeing in scenario 1, there is that one HCC code that was captured. And in scenario 2, again, same patient, you're seeing all 3 HCC codes that were captured. Now the difference is 0.702. And like Leonard mentioned, the smallest amount, that's a huge difference, right? For an impact of this single patient, it's $5,000 difference. But even if the difference is less, let's say we're taking an average of about 2,000 for a portion of your population, let's say on average, and about 3,000 beneficiaries, then the difference in that population is about $6 million for capturing or recapturing the correct HCCs. And also for those ACOs in the shared savings program, annual wellness visit can be leveraged to attract kind of younger, healthier patients, specifically those whose risk scores underpredict spending with a RAF of less than 1.0 to lower the total benchmark, or conversely, again, on the other side, the increase of risk adjustment benchmarks, so proper cost of care can be established for your population. On the right side, what you're seeing is kind of changes that are going to be occurring in 2024 for ICD-10 codes and HCCs, and they're going to have an impact. So there are some changes at HCCs. Now it's version 24, which has been that version for years, and they're switching to version 28. So it's an updated version. So there are about 268 new ICD-10 codes being added, and over 2,000 that are going to be removed. Now, some of the 268 codes don't really impact Medicare, but might be helpful for commercial markets using HCC codes, like congenital malformations or deformations. But another change that's happening is an increase of HCCs, so from 86 to 115. The positive is there's more HCC codes and more organization to the RAF system. The negative is the grouping of those HCC codes, which can have a financial impact. And a good example of this is really diabetes. There's 3 categories before with diabetes, which will now be combined to one category with the same coefficients. Before they were different. So this might cause a downward risk adjustment change to beneficiaries whose health status has not changed at all from the previous year to the 2024 year. Really, what the importance of all this is that there needs to be more of an effort to get these beneficiaries to see a provider for an annual wellness visit, not only for HCCs and risk adjustment, but also for closing gaps that will help with value-based care agreements and then RAF scoring, right? So it's important to get the annual wellness visits done and code the correct conditions as well, so you can establish the proper costs. And on top of all that, again, we kind of touched on this earlier, is that network leakage piece, as well as keeping your populations within that referred network. Kind of going into really how plans and providers engage with patients to get better outcomes. This is where kind of we jump in and help out. So some of the main strategies that we have here at mPulse Mobile is the natural language understanding and that conversational AI. The third component is that behavioral science, health equity, and streaming content, and I'll dive a little bit deeper into those. On the next slide, what you see is conversational AI technology and natural language understanding, which we acronym NLU, which allows us to communicate with patients in a way that feels familiar and addresses their intentions and needs. Right, a lot of people are communicating via text message. That's very familiar. Baby boomers, no difference. My parents adopt, again, the same kind of technologies using the phone that they didn't do 10 years ago. Now they do the banking, healthcare, it's all on the phone. And again, humans are human. So we design our solutions to meet them where they are instead of expecting them to really act like machines, right? So we accommodate for like typos and slang for incoming messages to determine the intent of that patient. So that helps us address their needs in the moment and then results in a better experience and better outcomes, not just their ability to use keywords correctly. And again, this helps with achieving higher patient satisfaction by connecting patients to the information or resources they really find most valuable when they express that need. Kind of moving on to that other piece that I was mentioning, which is a behavioral science, right? So we use instructional strategy while being conscious of disparities and inequities to engage with our patients. So I'll begin with instructional strategy. What we want to do is captivate, educate, and activate. This means that we engage with proven methods similar to what Netflix, Amazon, YouTube do. I'm sure maybe you've seen, again, the shorts and stories feature over there. That's something that, again, we incorporate because that's what works. That's what people are familiar with. And we educate on the importance of health outcomes that they would benefit from sustaining engagement to improve their health, and then activate by getting them to take an action and really making it easy to do so. So this could be a quick scheduling service or connecting them via text message to care managers, call centers, or other options that you have available. And then all the conversations are analyzed and then passed back to the healthcare organization to better understand your population's barriers and information, and then really how they perceive healthcare. Then moving on kind of to health equity, each population is different, right? Whether it's Medicaid, Medicare, or commercial, they all have different goals. And then by leveraging solutions with health equity in mind, we want to help reduce those disparities, right? So some examples include outreach and digital content in multiple languages, culturally relevant programs, and more. One example which addresses barriers, and it's actually published in the JMIR journal that we did, is our COL Fit Kit program that we ran for an FQHC in Los Angeles. And they have a really large Hispanic population that didn't complete their COL screenings. And the results are really great. You can actually see the link and summary of the program on our website's resource page under blogs. And the final piece, which is behavioral science, right? So this is changing the way people think and understand healthcare through proven behavioral science principles. Many people don't know how bad diabetes can be. I can tell you a lot of my family members don't know that. And they don't understand that diabetes can affect your heart, kidneys, and eyes, right? So we use many behavioral science principles in basically all our communications and solutions. And some of those I'm going to highlight real quick is loss aversion. So that's really conveying a message. If you don't go to get a preventive screening, you can lose out on the things you enjoy. For diabetes, again, it could be losing your eyesight, right? Then there's a storytelling effect, using different methods of communication, communicating really that message, not just a long email or text. So we do this through photo novellas, animated videos, and more to help patients understand and retain that information. And then finally, another one that is one that always kind of comes up in our solutions, that spark effect. So you want to make health actions easy to do. You might have heard the saying, like, keep it simple, stupid, right? Well, that's what we do. We provide direct links to complete the desired action and then make it easy to do so, all on one mode of communication if possible. So if you start on a text message, we want them to finish on a text message, not need to call or anything like that, right? So we want to hook them again with the content, educate them, and then finally get them scheduled by kind of clicking a phone number to schedule or a link that we provide, all on a single platform. And right here, you're kind of seeing the patient journey. So studies show that just after 1 hour, and I'm totally in this, people retain less than half of newly presented information. It gets worse thereafter. After 1 day, it's 70% of new information, and then after a week, it climbs to 90% of information that's forgotten. That's why we really have multiple touch points in our programs, right? One message might not be enough, so we continue to build on top of that. And then trust is built, right? When better patient experience is given. So that trust creates an open line of communication, for other gaps that need to be really closed, right? An example you're going to see over here, starting with the annual wellness visit, you see a few touch points over there, and then continue the conversation to another gap, which is diabetic eye exam. And then really what we do is we manage the whole program from the cadence scripting and then passing all that data, which includes engagement rate, responses, and more back to you to understand your population. And really these encounters lead to improving other outcomes as well, like overutilization of the ER and more. And that's really what you're seeing on the bottom left of the screen. Kind of diving into the first month, and this is the annual wellness visit piece. And we're really highlighting that annual wellness visit journey, right? So this is an initial message to educate and make them aware of the annual wellness visit. Then the reinforcement message, which is following up with them to make sure they will schedule. If no, we do that barriers assessment. And that's what you're seeing over here. They didn't respond with an option presented, and our NLU didn't stop the conversation, but continued with ride sharing resources, right? Because then it might break the system in other kind of situations where you have to call a number right away, but this is actually giving an answer, or we can also feed content through here to give them an answer based off of what they said. Continuing to month 2, and this is where we have the diabetic eye exam. This is our streaming health content. So it's similar steps to the journey, but in this one you're seeing one of the hundreds of streaming health content we have to close gaps. Here you're seeing a couple of behavioral science principles, one that I did mention, loss aversion on the right. And the viewer is seeing what can possibly basically happen if you don't get your diabetic eye exam, rather than a text message explaining it. So a lot more information can be conveyed in this 30-second video, and that's really impactful. For one client, we saw a 64% increase in diabetic-related visits after incorporating this program. So let me play this for you real quick. So you're getting that intro message over there. Again, I think of this as kind of like a bait. And this is where we kind of take that social media presence, right? The Instagram short stories. And it's kind of showing you how, if you don't get your diabetes in check, don't get the eye exam, these life simple pleasures can be taken away, right? So here's diabetic retinopathy, before was glaucoma. And then over here, you're seeing, I believe it's cataracts. And again, from that first message to the end message, and that's really important, that bottom piece, schedule yours today. You're talking about a minute total, right? And that's a really important piece of it, because again, you want to get them all on a single platform, keep it relevant, and then make it easy for them to do that scheduling. And we have hundreds of different kind of streaming health content for different gaps for each journey. The one that I see come up most, again, is probably ER diversion, cancer screens, and then medication adherence that people are really most interested in. Finally, again, the third month, which is that bottom piece over there, what you're seeing over here is understanding, again, the education piece, right? The type 2 diabetes, tips on eating healthy if you have diabetes, and then medication adherence programs for refill reminders. Now, these programs can be standalones with just an annual wellness visit, or kind of combined with other health outcomes like we've done in the patient journey over here. Garrett, going to pass it over to you. One more polling question. Would appreciate answers coming in on this one as well.
Right. So this one is, how are you currently engaging with your patients digitally? And so you can select all that apply. Obviously, paper mail isn't digitally, but you get the idea.
Yeah, threw it in there because a lot of people still use paper mail. So
sure, but it is effective in certain areas. So
yeah.
Okay, we still got some answers coming in here, so we'll give it a few more seconds. Okay, looks like most everyone has answered at this point, so I'm gonna go ahead and close it down in 5, 4, 3, 2, and 1. Close, and then I'm going to share the results. All right, Aram, are you able to see that on your end?
Yes,
I can see.
Awesome. Yeah, that's great. Again, that SMS text is interesting, and it's come up a bit in the recent years. Paper mail, that's 60% is high, because I think the average cost of a paper mailer that I researched on last time was about 58 cents with postage, and that's pretty high compared to what a text message would cost, right? And then again, understanding kind of the results of that, how good does that kind of work is interesting. Email, I rarely use my email. So I have so many other emails kind of coming in. The good thing about SMS is that you can actually, it doesn't go to spam or junk. You're actually seeing it there. And most people are really happy with kind of engaging if it's about their health, especially in the Medicare population, you know, as you're aging. Would be interested, Leonard, kind of as what you think and kind of what you guys are doing over there.
We're probably doing all the above. Paper mail has dropped off. We did a lot of phone work. That seems to be leveling out as well. Text is a great option for those that have smartphones and even some of the old flip phones. But I think this is a portfolio of approaches, and you've got a little bit in everybody. Not everybody's in a cookie cutter kind of response. We have some older patients that are more comfortable with paper mail. So yeah. I don't think there's a wrong answer. It's just, what's the mix that you use to communicate, and engagement's the end game, and the path there is important, but not as important as the destination.
Yeah, makes total sense, 100%. Depending on your area, again, maybe in rural areas, again, there's less use of SMS, but it does make sense to have a healthy mix is always the best.
The one thing you mentioned, Aaron, is that the fact that we're using some of the science, behavioral science behind things. I worked in a marketing organization at one point, and everybody that I met there that was involved was a PhD psychologist who made the transition into understanding consumer buyer behavior. And the fact that we're adopting that in healthcare, because it's existed for forever, not as automated and not the AI side of the world, but it's a key tool, and we should be using those things like any other enterprise, or any other sector of the industry. So that alone is a big movement in healthcare to try to adopt good science and good practices to apply to our business.
Yeah, makes a lot of sense. It always seems like when I talk to people, healthcare is always kind of 10 years behind some of these other industries. So it's good that we're kind of seeing more adoption, especially in the past couple of years. So yeah, totally agree with that. Moving on. So here's a case study that we have for annual wellness visits. So we use SMS and IVR. Again, we were just talking about how it's good to have a mix. So it's always better. Yeah, if you just do SMS, that's great. But if you have a mix of SMS, IVR, email, whatever it may be, that's always great, right? And it's used in this case study. So we scheduled an annual wellness visit for beneficiaries who have not scheduled an annual wellness visit or attended their visit yet, right? And results really show great engagement rate, right? So it's 18% of members engaging with content who didn't have an annual wellness visit for over 2 years. So that's really that unengaged population, not the ones that are really scheduling it. They're people that have not scheduled in the past 2 years, which is a long time, right? And the reach rate is almost 100% for SMS, right? So they didn't really bounce or anything. And then the IVR reach rate is amazing as well, with 16% even calling back after receiving that voicemail from the program. So this is one of the really great programs that we have that highlights kind of the use of an annual wellness visit and how successful it can really be. And healthcare, again, ownership is important. So I'm sure many of you felt this at some point, as have I. Navigating healthcare, pretty confusing, right? Whether you're a member, patient, doesn't matter, it's the same thing, right? So giving the resources and educating patients really empower them to take control of their health, and that's very valuable. You want to be brought into the health journey, right? And not only do kind of what they're being told without any context or understanding, and that's really picked up the past few years, where people want to understand what they're doing and why they're doing it, right? So this is a really big piece, and again, you're seeing kind of how it's improving health outcomes across the board over there. Social isolation, that's something we went through, again, pretty heavily during COVID, and then everything else that we've kind of been mentioning throughout the time as well. Final part of this presentation, again, is the cost savings and then the ROI, right? So kind of moving on here, we created an ROI model over here for the annual wellness visit program specific to risk adjustment. So this is sourced, the data in here is sourced from the Society of Actuaries, and it was estimated that the average value of an HCC code is 1,080, with an average number of HCCs per member being about 1.5. Now, obviously, this is completely relative to the region and your population, so you can kind of plug in the correct numbers for your organization. We'll be getting these slides kind of after, so you can look through it. So if you're looking, inserting your population size and those without a risk adjustment, but to keep it simple, again, what we've done is just put 100,000, so the math becomes really easy, right? We took a low average of about 20% without a risk adjustment visit, which is about 20,000. Then our program average impact, which is about 18%, gets you 3,600, right? 18% of that 20,000. And then finally, average value of HCC, 1,080, and then HCC captured 1.5. So if you multiply 3,600 by 1,080 by 1.5, you're getting the numbers that you're going to see to the right over there, right? So it's a monthly potential savings of 486,000, and then a yearly savings of 5.8 million. And that really doesn't include the other benefits from an annual wellness visit. And those benefits are listed here. There's a lot of them. We've talked about some of them. I picked two that I want to highlight really quick, and that's closing gaps in care. There are over 10 quality measures that can be addressed during an annual wellness visit. As mentioned earlier, 45% of Medicare beneficiaries have 4 or more chronic conditions, right? One of the most common being diabetes. So breast cancer, COL, medication adherence, and other preventative screenings can also be addressed during this visit. But to really put this into context, in 2023, recapturing diabetes without complication is a 0.105 risk value. That's actually going to be going up in 2024, again with version 28, to 0.166. So, but if you're looking really at the 2023 value going off of that, really recording diabetes without complication, it averages about $983 adjustment. And another one, again, that I want to kind of go over is a reimbursement for annual wellness visits and ACPs, right? So since Medicare also wants to encourage primary care providers to complete these important services, reimbursement rates for an initial and subsequent annual wellness visit often equate to about 50% more than a typical E&M visit. So the national average for subsequent annual wellness visits is about 130 for an IPPE, initial preventative physician exam. The nation is about 167, and that's the same for the initial AWV. So on top of that, if you do the ACP, advanced care planning, those codes added will be another $83. So if we take an initial annual wellness visit and we averaged it, again, 167, and then a 30-minute ACP, which is about $249. And if a portion of your population shows for an annual wellness visit, again, let's say 2,000 beneficiaries, you can get over 500,000 in reimbursements. So that's a big amount, right? When you're adding all of these different things that can happen during an annual wellness visit. And I know we're getting kind of close on time here, but one more thing, again, that we've been talking about is that ER diversion, which is another major area that helps with risk adjustment. So we have great ER diversion programs, but our research really shows that preventative care visits and proper education of an ER versus urgent care really lowers utilization. And it also can, again, impact the physician and care team burnout, and really stay on top of keeping those total costs of care down. I'll actually be hosting another webinar with BBC next month around ER diversion, so we can dive a little deeper into that and really have a discussion around that. I think we're at the end over here. Q&As, Garrett, I'll pass it to you.
All right. Well, that was a great presentation, guys. There's obviously a lot there and a lot to discuss. And we do have a number of audience questions that came in. So in no particular order, I'll dive into these. If you do have a question, go ahead and submit it now using your control module. There's actually a questions area that's different than the chat. So go ahead and put it in. If we don't get to yours, though, don't worry. Someone will reach out through email or text or mailer. No, I'm just kidding. No, but we'll reach out through email to answer that for you. So let's dive in here. First question is this. What is your connection rate with text messages for different populations like Medicare and Medicaid?
Yeah, so we do have an average connection rate for those populations. For Medicare, it's actually 40%. And really, the industry average is 15% for Medicare. So that's significantly higher. Medicaid, we all know, it's hard to get phone numbers. It's really a tougher population. So you're going to see kind of lower on that. It hovers around 20%. But again, that's really 3 times higher than the industry average, which is usually about 5 to 7%. And then for kind of commercial and commercial payers, I think, again, it's about around 35%. So just to kind of put it into context, we ran a program in rural Oklahoma for a Medicare Advantage plan, and they had never done texting before. And we actually saw a 50% engagement rate with them, which is really high. Again, if you're never doing texting, you're expecting, again, it not to be that great. And we got 50% engagement rate. So it really does work. People kind of think, again, Medicare people don't text, but a lot of them do. And over 95% of the population has a cell phone, and really about 85+% of them are smartphones, and it's only kind of going up, right? So it is a big piece, and it really helps out a lot.
Great. Next question here is, what type of data do you get around barriers or social determinants of health from your programs?
Yeah, so SDOH and kind of barriers data, that's a big piece. So one of the main things, again, I mentioned earlier was those the language preferences, right? It's really important to know language preferences. Basically, in all of our programs, English and Spanish are pretty much standard. It's good to have them. They can kind of switch over by responding to the message in ESP, and then all the messages will come in Spanish. We can even do the video content in Spanish. And then you saw in kind of the barriers assessment earlier, the transportation one. That's one that we can figure out cost of medication or not being able to kind of afford healthcare. And then, of course, kind of the question. So we have programs around HRAs and social needs kind of surveys, right? So you get a bunch of information on that. It really depends on organizations' preferences. You can do, again, food insecurity, housing, physical safety, education level, and more.
Great. Next question here is actually, do you provide remote patient monitoring services?
Yeah, so we don't do RPM services. No, that's not actually something that we do, but we might work with companies that do RPM services to kind of really improve the engagement rate and communication with those patients that are at home.
Okay. This next question is sort of a multi-part question. We'll just kind of go through it a little bit at a time here. Annual wellness visits, or AWV, is tied to Medicare. How do you plan to spread across to Medicaid, commercial, and general population?
Yeah, so it is tied to Medicare, but then there are preventive visits on like the Medicaid side. So again, the messaging is a little bit different on the Medicaid side, and even commercial plans are adopting that annual wellness visit as well. So we do some annual wellness visits for Medicaid, and I can give a little bit more context on that. I know we're kind of running out on time, but that is something that we're doing and really spreading into those other areas as well. But it is a Medicare thing. But again, with value-based care, a lot of kind of ACOs adopting that Medicaid model. It makes a lot of sense for Medicaid and commercial to also be tied into that. So we're seeing a lot more of that, especially recently.
Great, and we are running kind of short on time. So, and that question was a multi-part, but we know who you are. We'll reach out to you and answer all of your questions there. One last question here is, are you using any digital tools or platforms to perform social determinants of health risk assessments?
Yeah, so again, we have a behavioral science team. We have teams that really engineer these solutions and work with healthcare organizations. So we have the best practices that we know of on kind of those screening social needs tools, things like that. But then it's really the questions, right? It's really kind of what I mentioned earlier, understanding what questions need to be asked and taking them to a secured site. If the healthcare plan or provider has those surveys, we can, of course, get those on a text message. What we do like to do is not keep text message surveys, really keep them under 6 questions, because then, again, you lose that engagement rate. If you have kind of a secured site, we can move you over to that secure site. Or again, short questions can be on a text message. So we really do that and it works pretty well as far as engagement and responses.
Great. Well, unfortunately, we're out of time for questions, so we did have some additional ones. Again, someone will reach out to you if you have one last minute here. Go ahead and ask it, and we'll get to you as well. I believe, Aram, you wanted to say a few words about the Activate 2023.
Yeah. So we've been doing this for a few years. Great conference. This is our company conference that we hold every year. wanted to quickly plug in the 2023 Activate Conference, again, coming up September 27th and 28th. All attendees to this webinar, you get free registration, so we'll cover that. There'll be great discussions around improving quality, consumer experience, and then health equity. Again, that's a huge topic. It's been going around a lot. I've been seeing it a lot the past year especially. You can visit our website for more information, or you can reach out to me via email. I can help you with the registration, get you over to the marketing team. So I'd appreciate anyone that's interested, just let us know.
Yeah, and actually I am putting in the chat here a link to the whole audience if you wanted to find out more. But what I'll also do is when I send out an email to everyone afterwards with the link to the recording and to the slides, I'll put a link in here as well to the Activate event, so you can check that out. As we conclude here, I just wanted to encourage you all to head over to bbcexhibithall.com and check out the mPulse mobile virtual exhibit booth. There's a lot of great resources here, and you can kind of get a snapshot of what they're doing in the value-based care space. Check out different resources that they have and engage with the team there. That way you can really educate yourself, and then you can actually reach out to them directly through there. Or if you'd like to reach either of our speakers from today, their information is here, and feel free to reach out directly, or I'm happy to facilitate an introduction as well for you if you wanted to reach out to me. So thank you all so much for attending. Really appreciate your time today. Leonard, Aram, wonderful job. Thank you guys so much for your time as well. I hope you all join us on our next webinar. Have a great rest of your day.
Awesome. Thank you.
Bye-bye.
Bye.
Thanks, Ryan.
Thanks, Leonard. Appreciate it. That was great.
Yeah, likewise. Nice job.
Yeah, you did really great. I really appreciate all the context and information. It was very, very helpful.
My pleasure. Thank you. How do you?
All right.
Yeah, we'll catch up. I'll look forward to talking with you again.
Yeah, we'll catch up after this.
Yeah. All right. Sounds good. All right. Be well.
Have a good one.
Bye-bye.